begin by, first of all, a small apology. I am yet another victim of the same bad health of this city periodically. Running a very bad sore throat, and therefore you may find my voice hoarser than what it normally is, and having periodically cough, so apologies for that. But I also want to start with a bit of disclosure. So I was introduced by the host. So let me say that whilst I do dabble a little bit in writing on ethics, on public health, but primarily I am, like many other doctors in this city, a part of the jungle that is medicine, surgery, relatively advanced specialty of surgery. But I also have a bit of a schizophrenic existence, and this schizophrenic existence is the fact that I spent about roughly half my time in the private sector in this hospital up here. And as you know, this is a hospital next to the gigantic house of the richest man in India, which I have the misfortune to see every day. And I spend around half of my time in this hospital, which is, I take this bridge 4 times a day to go to the Haba hospital, which is one of the peripheral hospitals of our municipal corporation. And this is a hospital which serves the large slum pockets that exist near Bandra. Bandra station, if many of you know Bandra East. So the classic Danny Boyle's slumdog billionaire slums. So that is Baramana, Berinagar, etc. And the reason I say this is not just to give an introduction about myself, but to say that whatever we discuss about healthcare, this is the big elephant in the room, and there is no way we can avoid recognizing that we are there are two worlds out there, and two different forms of healthcare, with two parts, two sections of our society get. Now, I don't want to read through the slide, but this is something that Dr. Sundaraman referred to, and I think it's very true, that we have to talk to our colleagues, or for that matter, talk to ourselves, and really ask the question, why should we be discussing empathy and ethics? So it is actually a very selfish reason, and this is only about 10% of us are going to die a sudden death, which means the other 90%, 9 out of 10 in this room, you're going to get some health care at some stage, whether it's a degenerative disease, whether it's a cancer, whether it's an ischemic heart disease. And therefore, as this is actually from Susan Sontag, where basically she says that we all live two different types of citizenships. And sooner or later, we will have to be on the other side. And therefore, being on the other side, recognizing how it is to be on the other side is not about some lofty aim of being the socially good, etc. It's a very selfish thing that we should be addressing. But why now? And why is it becoming important now? I think it is becoming more and more important now, and I suspect that maybe the provocation for the organizers of this meeting is the fact that we are seeing a severe trust deficit, or you can say an empathy deficit between doctors and patients in this country, leading to not just some vague distrust or antagonism, etc., but leading to huge amounts of violence. And I'm sure all of you sitting in this room are aware that this violence is relentless, continuous, and taking more and more bizarre forms. It's a separate subject in itself, and I have actually written extensively on this topic. But the fact of the matter is that this is actually a tracer of mistrust and a lack of empathy. Now, when we discuss empathy in healthcare, I must first flag that there are some assumptions we may be making. And the reason I'm flagging these issues is because if we make wrong assumptions, we will go along the wrong way. And therefore, it's important to mark these assumptions. Is empathy a distinct, definable entity that lends itself to pedagogy? Which means that can you teach empathy? Is there a syllabus for empathy? I'm not very sure about this. Are doctors open to recognize this deficit, learn and change? I have some doubts about it. They call me a cynic, but I have spent many years trying to talk about ethics, talk about the challenges that we are facing in terms of the distrust and violence. But I suspect that the open minds are not there. Is the mistrust in healthcare? Is it about personalities, personal behavior of doctors, or is this structural? And I think this is one of the key issues that I would like to emphasize today. That whether just putting the burden on an individual doctor and improving their behavior, partly goes back to Sundararaman's talk, but is that going to be the key? Is that going to change things? Or we need to change the way the healthcare is structured? I think partly even Mayor Strong brought that up. Finally, and this is a question that is actually troubling me in a big way, the more I engage, the more I discuss, the more I read. Do today interests of patients and doctors converge? I have some doubts about this. The way we have gone about constructing healthcare in this country, I have severe doubts whether the interests of patients and interests of doctors actually are converging or not. And the reason to flag this issue therefore is that when you start talking about empathy and teaching empathy to doctors and patients like that, we must keep all these perhaps nebulous and partly faulty assumptions in our mind. So what is the setting of healthcare? So this is, all of you know this, and all those who have engaged with ideas of health rights, public health, that there is differential power, there is vulnerability, these are very severely emotive situation. An illness is a very, very emotive situation. And therefore the importance of empathy, importance of being nice, importance of caring is critical. And a lot of my colleagues, when we talk about these issues, say that, look, don't engineers do this, don't other professionals, don't lawyers behave like this. And we often have to sort of say that, look, the situations are incomparable. Here we are in a profession where we have somebody dying, somebody is, sort of has a severe illness. And I think it's very superfluous to constantly compare this profession and its interactions with its, into inverted commas, clients with many other professions. And I think unless we accept this, the debate or the discussion often cannot be taken further. But I think this is equally important, perhaps more important, that when you move to India and South Asia, you have huge hierarchies and biases. And these are I have listed them out. I'm not going to sort of discuss all of them. They are obvious. But therefore, when you seek to teach somebody empathy, when you want the behavior of doctors to change and want to teach them, how do you deal with these hierarchies and biases that exist? It's very strong in our society. The health-seeking behavior of our population tends to lurch from, on one hand, blind faith to herd mentality. This is, I think, classical of our cultures. So therefore, individual critical thinking perhaps is not as sharp as it is in the rest of the world. And I think this also impacts in the doctor-patient relationship. But I think we must acknowledge, and I think both the previous speakers came back to this, and howsoever repetitive, cliched, boring this may sound, I experience this every day. That finally what is causing a lot of the heartburn, a lot of the angst, anger, and manifesting in various ways, and what we look at as lack of empathy is actually the whole issue of people having been forced into the private sector, being pushed to pay money out of pocket in the crisis. And unless we see this major fault and attempt to correct it, all appeals to individual doctors, all attempts to teach empathy may not go very, very far. And this is again something referred to by one of the speakers, I think it was Sundararaman. Doctors, so there is a construct of a doctor. The doctors don't try, you are tough, you're supposed to be, as a surgeon especially, I'm told, you're supposed to be very tough and you're supposed to deal with it, etc. And then empathy is actually somebody else's business. So I often, when I talk to my colleagues, my postgraduate will say, oh, this patient is crying, let's call the social worker. Something that Dr. Sundararaman said. This patient has a problem, let's call some counselor. Sometimes they will call psychiatrists. You will not believe this, that if a patient is crying day in and day out, they call a psychiatrist. And patients are diagnosed as depression in hospital, and of course our psychiatrists give them 3 tablets. So this whole construct that I am a surgeon, I am a physician, and all these other issues are somebody else's business, ESM business, nurses, counselors, I think also this is a big problem. So having given you this sort of background on what are the elephants in the room, what are the challenges, what are the cultural issues, let me address the question in the next few minutes is to become bang on to what I was supposed to address today. Can you teach empathy, or how does one teach empathy to all of this? So, one of the things I want to immediately flag is that there may be a tendency to equate empathy with certain constraints, and it is not. So, empathy is not good medical care or not efficient medical care. So, empathy is not some sort of how fast you can give a thrombolytic to a patient with a heart attack. Empathy is not communication skills, and I personally, whilst I respect all those who attempt it, but I personally very doubtful about what this whole business called communication skills. Because what it teaches people is politeness, saying good morning, good evening, but often I perceive that it seems to stop it. And empathy is also not charity in care. So I think we need to look at this, because when we talk about empathy and when we start promoting empathy, there may be a tendency to go in these directions and claim that therefore we are already empathetic. And what is this new empathy that you are talking about? We already reserve 10% of our beds for the poor, blah blah blah. And there is also a problem with medical education. I know I am sort of going into multiple areas, digressing, but we need to flag all these issues. So medical education is all about exams, degrees, academic advancement. How we fit all this into this construct, teaching empathy, etc. So there is of course something called pre-existing values and biases in a medical student's mind as they go along the way. There is of course institutional ethos. I think institutional ethos plays a very important role in the way a medical student's mind is shaped. I have no doubts about that, and I am not saying this because Dr. Chandley is sitting here, but I think, for example, CMC Vellore or St. John's or Varda, I deal with postgraduates from everywhere. I work in 3 hospitals, and I see, I perceive the difference, and I think this has something to do with the institutional ethos that exists in some of these places. Peer behavior, I think, is key. Students do learn from the way their seniors behave every day on the round, every day in the operation theatre. And I think peer behavior plays a very important, of course, role models. We will come back to that towards the end. So, if we have to teach empathy to doctors, what will doctors, or what will me or my co-host, what will we need to do? Besides accepting the deficit, we will need to step down from the pedestal. We need to see beyond immediate tangible benefit, because the medical profession is very aspirational now, like are many other professionals, and therefore there is a tangible benefit that they need to see in everything that's done. But they also need to free themselves from conflict of interest. And this is very important. Doctors, I have written about this many times, that doctors will be increasingly entangled in the business of medicine. They are investing, they are partners, they are owning hospitals, and I think this conflict of interest is a huge problem. And finally, of course, doctors need to think independent of hospital management. I can share this with you that I find that my colleagues in all the hospitals I work, I'm surprised that these are people who are 10 years educated, postgraduate, super specialty, but when it comes to dictats from hospital management, they all fall in line. And this is a behavior that we must understand. So, finally, I just want to come to trying to share with you what empathy should be, what it should be beyond those 4 or 5 tendencies that I shared with you that we may tend to equate with empathy. So, I think in the Indian context, it should be support and solidarity beyond day-to-day routine care. And perhaps try and share this with you in my next slide with a personal example. Improving access to care, reduce the financial distress of the patient, recognize and try and reduce discrimination, In short, think it also from the patient's perspective. Now, of course, this is all cliche, this is all sort of saying inane things, and how it actually plays out is something that needs to be seen. But so, for example, I face this situation very often, and I try and discuss this very often with my postgraduates when we are facing this situation. So, I often face major postoperative complications because I do this kind of surgery, prolonged stays and costs. So, here is what I have tried to do over the last 15-20 years in my practice. So, I try and explain all the potential risks in detail to all patients, families. If the family says, please don't talk to the patient, I say, no, the patient must know that he is or she is going in for a major operation with complications, even at the cost of, into inverted commas, losing the patient. You know, these are all interesting terms, but I'm sorry to use such crude terms, but it's important. For those who are paying out of pocket, I recognize that immediately and try and get them subsidies. I do the largest number of operations in Jastok Hospital in the free class. And I must share this with you that I always get a bed because none of my colleagues are really keen on doing those operations. So I'm lucky. In case of complications and prolonged recovery, I often waive my charges. My colleagues tell me that by waiving your charges, you are admitting to a problem. There's a narrative that if you waive your charges, the patient and the family will feel that you are admitting to a problem. I don't think so. I've never faced that problem. This is my personal act of solidarity with the patient and the family, and I can share this with you that an average doctor in an average hospital, by waiving 1 out of 10 patients' charges, is not going to get financially devastated. Be very sure about that. I try and obtain generic drugs. I have actually fought with hospital managements to get on board the lower cost. Generic in India, by the way, is a very different thing. What we are talking of is branded generics of big companies, which are sometimes 1/3, 1/4 the cost of the leading brand. I have often sent patients outside the hospital with permission because the cost can substantively come down. I often ask the billing department of the hospital not to communicate directly with patient but through me, because they can be very rough and crude in the way they talk to family members. And sometimes the way you put it, that's important. I often let patients off with pending bills to pay later. My colleagues often say that this is dangerous, but I want to share this with you. The last 15, 20 years, I think I've done this about 40 to 50 times, and 90% of patients, families will come back and pay later. Just that they need time, they need to be told that we can give you time. But if you try to force them and say pay or we don't discharge you, that's a deadly situation. I asked of the hospitals I work not to hold back the body in case of a death if the bill has not been paid. I say that I will take the responsibility, and it's only on 2 or 3 occasions that I had to pay the bill. By the way, large hospitals in this city deduct the amount if a bill is not paid for, often from the consultant charge. Take this very clear message. So when we talk about empathy, it's not the individual burden of the doctor, but also the burden of the hospital, and that's the point I'm trying to make. The structural empathy. Also, none of these hospitals are likely to go bankrupt if they occasionally have to waive charges. I suspect that none of them will go bankrupt. So this is the difference that I was talking about. I often help out the patient in transport back to where they come from. It's a small gesture, but important gesture. They don't mind. If you call up, ask your resident doctor, you call up the ambulance, say, we're organizing. Speak with the local GP doctors. The patients who are referred back because they have advanced illnesses, but ensure that they go back to somewhere. Ensure that you talk to them, some doctor where they are going to. In case of transfer to a public institution, and we do occasionally transfer patients, I try and ensure that I get over to a doctor, talk to that person in the public institution, say that, look, this is the problem, we have run into a problem, the family is running out of money, can you take over the patient? And luckily, because I work in those places, I continue to work in a public hospital, I can manage to do it. But if you just put a patient in an ambulance and say, go off and go to some government hospital, I think that's the classic case of potential for huge anger and violence. And I think if somebody does a study of the cases of violence in this country and these doctors, you learn a lot about where we are going wrong in terms of empathetic behavior. Now, finally, can we have some creative approaches to empathy? Because I sort of tried to tell you that I'm a little doubtful, a little cynical about teaching empathy as in a pedagogical manner. So can we have alternative approaches? And this is our looking at. So can we tweak entry criteria for medical education? CHC well or so if you have institutions who have a strong faith, who have strong sort of ethos, can we tweak them? I think Zafarullah Chaudhary for many years in his hospital in Bangladesh, in medical college, decided that unless you do 3 years of nursing, you will not be, you will not get entry to medical college. So something like that. So can we tweak entry criteria? Because what are the current entry criteria? Some funny marks that you get in some funny exams for NEET, where you go to some classes and get some sort of 98% and then you are sort of therefore good enough to be a doctor. How do we reward people who are relatively more sort of empathetic in their day-to-day work?
Faith-based would be what? Community-based?
Sorry?
Faith-based is...
No, faith-based is often hospitals run by religious organizations, is what generally when we say faith-based. Reward patient feedback. If hospitals can sort of in their marketing sort of activity look at what is patient feedback, what do patients want, what do the patients see as a good thing in a particular doctor, and reward the doctor for that rather than rewarding the doctor for large volumes of work. Which currently seems to be the only way, one of the only things that we